Hi everyone, this is Adam Ferrier speaking again. Welcome to this presentation that gives an overview of the way in which quality is managed on a national level in Australia. Before we begin, I'd like to acknowledge the Wurundjeri people of the Kulin Nations, their leaders and elders both past and present, the traditional custodians upon whose lands the La Trobe University, Melbourne and City campuses are situated, and also to the traditional custodians upon whose lands you may be listening to this presentation. Now, you may be surprised to see some bilingual nature of these slides. This lecture comes from my substantive position when I teach in China. Unfortunately, I don't speak Mandarin myself. The most I can manage is some rudimentary German and Latin. However, what I hope to cover in this presentation is the antecedents of what led to the development of the Australian Commission on Safety and Quality, a brief description of the Commission itself, and what's perhaps most important for you in your developing up your projects, the indicators of safety and quality. Now, in doing so, I want to give due acknowledgement to the Emeritus Professor, Dr. David Legg, whose work I have used in some parts of this presentation. I'm approaching this lengthy presentation from the perspective that most of the information contained herein is new. I have to cover sufficient information for people from a wide variety of experience in education, and if you're already well versed in healthcare quality, you might consider this as revision. Nevertheless, I found that when I first went through the work of Dr. David Legg, much of it was a revelation to me, and it often explained things that, to be honest, I had only partially understood before. Dr. Legg has a unique ability to distill complex issues into simple concepts that I try to emulate. I really hope you find the same value that I did. Uncoordinated safe provision of health was something of a hit-and-miss affair in the past, and it was dependent upon the luck of finding a competent medical team and practitioner. There were pockets of intense goodwill, but often quality and safety took a second seat to hospital profitability and deference to status. Medical staff enjoyed wide-ranging powers and were treated as gods by staff. They could, and did, practice without fear of any real supervision or accountability, and zealously guarded their rights to self-determination. Now, this was understandable. The vast majority sincerely practiced to the best of their ability and endeavoured to provide the best possible care to the patients. Nursing was often dependent on rigid and ritualised procedures that often lacked any evidence and were often designed to keep nurses constantly busy. Despite this, Australians have always had a high regard for the safety and quality given in healthcare, even if their own particular care was suboptimal. The last thing on an Australian patient's mind if needing treatment is the idea that they'll receive bad healthcare if they go to a hospital. But this is in stark contrast to many other countries where the provision of health, even Western-style health, is regarded with fear and suspicion. In places like the People's Republic of China, the workers' paradise, healthcare is exorbitantly expensive, and a serious illness can result in intergenerational poverty. It is little wonder then that there is significant distrust of health providers. In a largely user-pay system, dissatisfaction with health provision can result in high levels of litigation, such as in the US, or even violence towards healthcare providers, as in China, where serious assaults and even homicide of healthcare providers is not unknown, as they have no legal recourse as in the United States. Now, the value of a universal healthcare system such as Australia cannot be underestimated. But first, let's go back and have a look at see why this has developed. During the latter part of the 20th century, quality assurance in healthcare was increasingly influenced by thinking and practice in manufacturing and other service industries and the emergence of continuous quality improvement, total quality management and organisational learning. There were some important parallels between the segregation of quality in various business sectors and the similar separation of responsibility of hospitals with clinicians responsible for quality and safety, but executive management not having much role. This was early on. One of the main features of changing attitudes to quality and safety in business during the mid-20th century was an increasing acceptance that executive management has a direct responsibility for quality as well as share price. With the rising influence of business thinking on healthcare came a new set of theoretical perspectives and frameworks through which to think about quality and performance, including increasing consideration of systems and procedures, organisational structures and cultures. The term quality control was coined relatively early in manufacturing. Quality control describes a process as based on the bad apple theory, that you inspect the products at the end of the manufacturing process and remove the bad apples, those products which are faulty or which do not meet the production standards. Now, this approach had two implications. First, it was inefficient in that the bad apples, which had to be removed, represented a waste of resources which went into the production. And second, that the quality control department was a relatively insignificant unit at the end of a production change. The rise of quality assurance in manufacturing as opposed to quality control recognised it would be a more efficient use of resources to get it right the first time, and this would involve closer attention to all steps of production further up the line. Despite this, the rise of quality assurance was limited because in many enterprises it was still being driven by a relatively powerless unit, by whatever name, was the successor to the quality control department. Quality assurance entered healthcare in around the 1960s and generally comprised of three elements. First was a capacity to review the services provided, second to study cases where problems were identified, and third to identify initiatives that might take such failures less likely in future. Despite this, there were two elements missing in these early quality assurance programs, namely action and accountability. Early programs were largely run by people that were enthused about quality in healthcare, who were personally and professionally committed to quality, but who were not part of the organisation's top hierarchy. This led to that review, analysis and recommendation of problems were not necessarily followed up by action and accountability. In this respect, the relative importance of early QA programs in healthcare reproduced the relative powerlessness of the quality control department in manufacturing. The successes of Toyota in exporting motor cars to the USA led to dramatic changes in this neglect of quality in the manufacturing. As manufacturers started to look at quality in terms of whole production sequence, an early approach was the concept of standardisation. This involved setting precise standards for the quality of intermediate stages in the manufacturing process and setting precise limited allowable tolerances, that is, a specified range of variation which might be acceptable. The concept of standards and limited tolerance of variation was accompanied by the use of closer measurement of key indicators and a focus on understanding the causes of variations. With this focus on measurement came a greater use of statistical methods for determining sampling rates and analysing variance. In contemporary business, Motorola's Six Sigma model is widely quoted. This approach is certainly well suited to mass production of standard products such as mobile phones. It may have less relevance in the clinical field, and some may consider it to be the antithesis of a client-focused model. That said, there appears to be an increasing use of this model in some health services, and by the people that do that, takes on an almost evangelical approach. In the early years after the Second World War, Japanese industry focused on light manufacturing for export, but its export products acquired a reputation for poor quality. This led to a deliberate focus within the Japanese industry on quality management in manufacturing, and it is in this context that the two slogans featured in this slide emerged. The concepts of continuous quality improvement and total quality management were developed in Japan, but broke into global discourse in the 1970s as Japanese exports started to make inroads into the US markets, in particular the auto market. These cars were cheap, but of high quality. Now, continuous quality improvement is about culture, creating a culture which is never satisfied with achieving any particular standard, a culture which is striving for infinite improvement. It illustrates the way in which prevailing attitudes may be part of the problem and part of the solution. The idea of benchmarking captures this idea of culture. CQI is also about measurement, statistics, and systematic tracing of causes. It builds on the practices of operations research and the investigation and analysis of causes, and committing to a change in which the way in which can be accountable within an organisation. Conversely, total quality management is about mainstreaming quality. Quality of product depends on quality in all aspects of the production process, making it the responsibility of executive management instead of just the quality care management, and involving teams in worrying about quality. And in doing so, the concept of a learning organisation is a more recent feature in this field. It arose in the context of an ongoing debate about organisational design, whether it's better to include the various units of supply chain within the corporation, and when it might be better to outsource or contract in non-essential elements of production. This boils down to the big all-encompassing corporation versus the small, lean, contracting-in model. The idea of organisational learning deconstructs this dichotomy by exploring the conditions under which large organisations can cope with complexity and uncertainty. Organisational learning is also about culture. Practitioners and managers at all levels and in all department sectors are encouraged to think about how they do their work and how it might be improved. Thinking also about changes in the external environment, about how their work fits into the broader directions of the organisation. The learning organisation seeks to maximise the benefits of local autonomy without losing the wider coherence. Critical to this is maintaining of the wider coherence is the idea of a shared vision. Another important development in management thinking during the 1980s was the idea of benchmarking and best practice. Benchmarking means comparing how we do things and how effectively we do things, and other organisations which do the same things or which do similar things. Applied to the healthcare system, this might involve a focus on patient reception and routing in the outpatient department, for example. We might start by looking closely at how we presently manage patient receptions to the outpatient department and then routing them through the various departments within the outpatient section. We might select a number of indicators which reflect measures of the effectiveness of the systems. We then identify a number of organisations, preferably those which reflect best practice in the industry, and then explore how our results compare with theirs and investigate why. The idea of best practice does not imply standards which cannot be surpassed, but rather it speaks about the organisation which exhibits best practice within our circle of comparators. For many years, medical licensure was seen as a necessary and sufficient for guaranteeing safety as well as quality of healthcare. This was partially due to the political influence of the medical profession during a period of ascendant medical hegemony. But in the 1990s, the prevention of wrongs became a matter of public policy beyond professional indemnity insurance, partly because of the publicity attracted to particular scandals and partly owing to the increasing role of public funding in healthcare. Studies demonstrating the morbidity and costs associated with healthcare wrongs led to an increasing focus on safety as well as quality. Another important change was initiated through this increasing focus on safety as well as quality was the increasing recognition of quality and safety as the responsibilities of executive management rather than being the professional concern of the clinicians or their lawyers. In some jurisdictions, the term clinical governance has become associated with this movement for managers to integrate a concern for quality and safety into the central strategic directions of the organisations. Executive managers now take responsibility for the risks and promises associated with the different investment options. And this brings up the issue of managing risk and what we can learn from business. The influence of business in the management of safety in healthcare has come through somewhat different pathways and has emphasised somewhat different issues. In the mining industry, problems related to safety arose primarily in relation to occupational safety measures. The number of miners dying in mine accidents bears a predictable relationship to the investment by the mine owners in safety. Depending on the strength of unions, the pressures of the marketplace and the stringency of occupational health and safety legislation, mine operators may choose to expose their workers to greater or lesser risks. Perhaps the most important lesson that healthcare can learn from mining concerns the calculus of risk analysis and risk management. Adverse events can be predicted, and given appropriately invested in safety, can be prevented. The pressures are different in the airlines industry, where the consequences of a crash in terms of loss of life and public standing are so much more catastrophic in terms of corporate interests. The airline industry takes an engineering and human factors approach to safety. This includes tracing through various scenarios associated with particular mishaps in order to place preventative measurements in advance. It also includes the principle of multiple backup systems. The concept of risk management has provided an integrative framework within which the whole range of strategies and models can be considered at the institutional level and be considered in relation to other functions of management, including financial management. There are many different activities, formal and informal, where information about quality, safety and risk may arise. The risk management framework enables information from all of these different sources to be considered and analysed, and where possible, strategies may be prioritised. The risk management framework enables the investments in safety and quality to be evaluated beside other purposes of the executive management. The modern paradigm of clinical risk management includes what was missing in the earlier concept of clinical quality assurance, namely action and accountability. So clinical risk management belongs to executive management, not to a group of enthusiastic clinicians with no leverage over management. So let's bring this back to what we do here in Australia. State governments are the principal providers of public hospital services, and in Victoria, a strategic decision was made to establish an authority at arm's length from the government called the Victorian Quality Council. The phased introduction in the mid-1990s of activity-based funding was a major impetus for the development of the authority. As we all know, case mix funding is a model of public hospital financing that ensures equity of payment to all public hospital providers across the state through a fixed payment upon completion of a patient treatment episode, which is usually upon separation of hospital, when the patient leaves the hospital, or less often the death of the patient. The value of this method of financing is that it encourages both standardisation of care and quality of care. The rationale is that the higher the quality of care, it is more effective, and this is expressed through a lower length of stay. Now, the Victorian Quality Council was headed by one of our La Trobe Associate Professors, Dr. Kathy Balding, and it existed from the 1st of July in 2002 and was disbanded in the 30th of June 2012. And the reason for this was the establishment of the Australian Commission on Safety and Quality in Healthcare, moving it to a national level. This was established in 2006 and has a role to coordinate the national improvements of safety and quality of health, and its enabling legislation is via the National Health Reform Act. It's a corporate government entity, so it's not part of the central government, but sits as a statutory authority, and it's funded by all governments of Australia, both state and federal government, on a cost-sharing basis. And it has since subsumed, it's moved the state organisations, which accounts for why the Victorian Quality Council was disbanded. So a little structure of the organisational chart of the Commission might be helpful so you understand the stakeholders. The Federal Minister for Health appoints the Board of Management, and it has representatives from the Commonwealth Government and all the state governments. It was also, it's a useful mechanism of having a Board of Management in this respect. It's a useful mechanism in a constitutional monarchical democracy, because if things go bad, the board is held accountable and can be sacked, while the minister and the government can maintain a standpoint of objectivity. Since the state governments are the principal providers or funders of public hospital care, naturally they needed to have representation. But there are other important elements that needed to have input, such as the private hospital sector and the primary health, because of the role of general practitioners in particular as gatekeepers to our health system. The Commission acquits itself each year by providing public reports not only of its operational functioning, that is, what its deliverables against its planned strategy, in their annual reports of operations, but also the outcomes and impacts in the form of qualitative outcomes expressed. Vital Signs is a rich source of information and inspiration if you are still stuck about developing up a project. Vital Signs describes the state of safety and quality in Australian healthcare and is published each year alongside the annual report. And these are available for download and reading from the website. The practicality, it's the Australian Commission on Safety and Quality of Healthcare is really quite practical. It's developed up a number of national safety and quality health service standards. And it's done so with a particular framework in mind. It's so that, in particular, patients and their carers are central to the safe delivery of healthcare. Working in partnership with health service organisations and their healthcare providers, ideally patients and carers or their representative bodies should be involved in the decision-making processes for health service planning, developing models of care, measuring service and evaluating systems of care. The reality is that the health service provision remains in the hands of so-called experts, believing them to be a benevolent force, but it's a dictatorship nevertheless. The goal is that patients and their carers, meaning family and friends, not hospital staff, will participate in making decisions about their own healthcare. But in order to achieve this, they need to know and exercise their healthcare rights, and not only be engaged in their healthcare and treatment decisions, but actually encouraged to do so. In practice, this rarely happens, largely due to the trade-off with having an effective funding model. Whilst the goal is for patients and carers to have access to information about options and agreed treatment plans, Consider the scorn of the professions for people actively searching out information, according to Dr. Google. Healthcare can be improved when patients and carers share with their healthcare provider issues that may impact upon their compliance with treatment plans. Now, the Commission has quite a bit to say this, and you can actually read their words on their website. I do encourage you to go and have a look at this website. The role of the non-clinical workforce is also important to the delivery of quality healthcare. The workforce may be paid or consist of volunteers, but by actively participating in the organisational process, including the development and implementation of safety systems, improvement initiatives and related trainings, the limitations of these systems can be addressed and identified and addressed. A key role for this group is notifying the clinical workforce when concerns exist about a patient or the physical environment surrounding a patient. Health service managers implement and maintain quality systems, materials, education and training that ensure the clinical workforce delivers safe, effective and reliable healthcare. They support the establishment of partnership with patients and carers when designing, implementing and maintaining systems. The key role of the manager, which most of you will become, is managing performance and facilitating compliance across the organisation and within individual areas of responsibility. They are leaders who can model behaviours that optimise safe and high quality care. Safer systems can be achieved when health services managers consider safety and quality implications in their decision-making process. And the role of health service executives and owners is to plan and review integrated, and I stress the word integrated, governance systems that promote patient safety and quality and to clearly articulate the organisational and individual accountabilities for safety and quality throughout the organisation. The explicit support for the role of patients and carers in safety, models of care, program design and review of organisations' performance is the key to the establishment of effective partnerships with health services management and the clinical workforce. Now let's get to the nitty-gritty of this. Published in 2012, Australia has identified 10 priority areas for the country. Let's look at each of these briefly. Quality, as we know from literature, must be led from the top down. This is why clinical governance is critical. A short word about governance. In my career, I've noticed a link between financial crises such as the 80s, 90s and the noughties that have led to the reform into the financial subsector, and subsequently these reforms have been adapted for the health markets. These issues should be discussed more deeply if and when you enrol in quality management and health subject. But ensuring quality and safety is now recognised as a primary responsibility of health service leadership, rather than being left to individual providers of health who happen to be employed by the health service itself. We know that reliance on practitioner registration is simply not enough to guarantee safety and quality. If quality and safety is not an executive accountability, then there are often tendencies for management to impose conditions in the interest of financial advantage that sometimes actively work against quality and safety. In terms of partnership with consumers, this standard in particular means that there is a push for the benevolent dictatorships to actively involve consumers in health strategic decision making, or at the very least take into account consumer perspectives. The reason for this is historical. We have had a legacy from the days of the charitable status of health work, particularly when a third party is funding that service, that people getting the service for free should just shut up and be grateful. This is no longer acceptable. And Australia is a relatively class-free society. I've refrained from saying classless society. But you can imagine the additional constraints that might occur if there were additional class boundaries, such as exist in the United Kingdoms or countries of the subcontinent. In terms of preventing and controlling healthcare-associated infections, these standards have been developed which are admirably pragmatic and practical. One of my father's favourite sayings is that common sense is not very common, and the prevention of healthcare-associated infections is a classic example. Everyone knows that hospital-acquired infections are bad news and can have fatal consequences for patients. Yet the old funding model for health service, which was a per diem bed day fee, was a perverse incentive, because the longer a patient occupied a bed, the greater the remuneration to the provider and the comparatively fewer resources consumed by the patient on each subsequent day. This is why activity-based funding or case mix funding is so important. It finally provided a financial incentive for health services to start actively preventing and controlling infections from a total quality management perspective, rather than an infection control nurse wandering around the hospital with a clipboard. Now, please don't misunderstand me here. The health professionals have always feared and fought nosocomial infections. In my professional lifestyle, I've seen changes in acute health, in particular where there are hand disinfectant solutions available nearly everywhere on the wards. Such introduction of things of where heat-sensitive instruments used in surgical procedures, such as colonoscopes, gastroscopes and laparoscopes, are no longer simply subject to disinfectant using glutaraldehyde, but are sterilised between uses. A potential downside of this is the wholesale move towards disposable consumables in healthcare. In operating for theatres, for example, reusable linen is increasingly being replaced by single-use paper-based drapes, which are incinerated after use after being washed and reprocessed for care. Nevertheless, the overall move is prevention is better than cure, and it saves money. Medication safety is another area of concern. Stephen Duckett states in the magnificent book, The Australian Healthcare System, that the most common health interaction or occurrence is a person taking a drug or a medication, either prescribed by a medical practitioner or selected with the assistance of a pharmacist, or selected by a person in his or her own initiative. There's a risk associated with the use of any medicine. It might be errors in the delivery of medication, such as the wrong medicine being prescribed or used, or the right medicine being used inappropriately. These types of errors are described as adverse drug or medicine events. There are solutions to prevent adverse events found in standardisation and systemisation, or making things as routine and standard as possible. Other solutions for reducing medication errors include improving communication between clinicians and patients, and using technology to support the recording and transferal of information, and providing patient information and clinical decision support at the point of care. This leads to the issue of patient identification and procedure matching. One of the most catastrophic errors that can occur in the provision of healthcare is the incorrect treatment being given. This can be as simple as the incorrect medication being administered, or as involved as an incorrect limb being amputated, and yes, there are documented examples of this occurring. The foundation of correct treatment is patient identification. A recent development in operating theatres is the introduction of time out, where prior to surgery being commenced, that is knife to skin, everyone in the operating room pauses to check that all the details are correct. Now, simple precautions like this are not only cost effective, but more importantly help towards preventing inadvertent disasters for patients. Clinical handover, the effective transfer of information, was also identified as an important initiative. Now, as most nurses know, handover can seem like a chore, especially if you've been looking after the same person for 9 days in a row. But handover is essential so that all members of the team understand the developments that have occurred and the upcoming care plan for the patient. Clinical handover is practiced in a large number of ways in all healthcare settings every day. The breakdown and transfer of information has been identified as one of the most important contributing factors in serious adverse events and is a major preventable cause of patient harm. Poor handover of information can also lead to waste of resources. The consequences include unnecessary delays in diagnosis, treatment and care, repeated tests, missed or delayed communication of test results, and incorrect treatment or medication errors. So it's just wider than just nursing. Blood and blood products are another area that are considered to be an essential area to be controlled. The administration of blood products is one of the riskiest routine interventions in hospitals. The risk of a catastrophic adverse patient event if the incorrect product is given to a patient is not only enormous but actually certain. In addition, because these products are often perishable and require careful storage in specially designed refrigerators and careful transportation requirements, there is a wide margin of error is possible. Australia has one of the safest blood supplies in the world, and there are comprehensive regulations that cover all aspects of blood donation and in the way that blood products are stored and delivered. But the transfusion of blood and blood products is not without risk and can lead to complications and adverse outcomes. They should only be given when the clearly indication and the expected benefits outweigh the potential hazards. The main areas that jeopardise safe transfusion is the blood sample for cross-matching is taken from the wrong patient, or the wrong name is written on the blood sample tube, or the patient did not need the transfer, and that bedside verification is not done correctly to ensure that the right product is being given to the right patient at the right time and in the right manner. The prevention and management of pressure injuries, and in acute hospitals is largely a nursing responsibility, is a particular concern. In the olden days, nurses like myself who were trained in hospitals had the fear of God put into us about pressure area care, and for very good reasons. Pressure ulcers are one of the most difficult preventable conditions to treat. The best and safest treatment is prevention. People who are elderly, debilitated, malnourished or have limited movement are particularly vulnerable, especially if they are restricted from moving due to fears associated with falls. Whilst pressure injuries are generally considered to be preventable, research shows that pressure injuries are a major contributor to the healthcare needs of patients within facilities. They impact significantly on the length of stay, the cost of care, health outcomes, and the quality and comfort of the individuals affected. Another area, surprisingly, is recognising and responding to clinical deterioration in acute healthcare. Rapid detection and timely responsive changes in a patient's condition, especially in acute hospital settings, is a critical responsibility, particularly for nursing staff. Whilst routine observations might seem a chore, as a student nurse I was often delegated this task and resented it as a menial duty, but I now understand how critically important the collection of data like this is for assisting the entire team. Strangely, the importance of this was never communicated to me as a student nurse, and it's shocking to me that this wasn't emphasised more. I trained in a private hospital where we didn't have registrars or residents, so nursing vigilance was all the more necessary. It's easy to simply think that this is somebody else's responsibility if a patient deteriorates, but we all have a role in ensuring that changes are noted and appropriate action is taken and communicated to the appropriate person. The worst possible case is that a patient dies unnecessarily, and no one wants to have the job of explaining to the coroner why this was not taken. Now, there are a number of common factors that contribute to failing to recognise and respond to deteriorating patients, and they're listed on this slide, such as not monitoring the physiological observations consistently or understanding the changes that have been found, a lack of knowledge of the signs and symptoms that could signal deterioration, a lack of formal systems for responding to deterioration, a lack of skills to manage patients who are deteriorating, and a failure to communicate clinical concerns, including handover situations. All of these are so depressingly common and so easy an error to make. And finally, the 10th area for action is preventing falls and harm from falls. People in unfamiliar environments are at risk of adverse events happening to them. Some fall prevention strategies of the past, such as the use of cot sides in hospital beds to prevent people rolling out of bed and falling to the floor, actually may have the effect of increasing the severity of a fall if a person climbs over the top of them in order to get to the toilet without an assistance, often due to embarrassment. And I saw this happen during my first week as a student nurse and on the wards in 1984. Other strategies, such as physical restraints, are now actively discouraged, if not banned. Technology has enabled the development of pad alarms, for example, that can alert staff if a person tries to get up from a bed or a chair. And some hospitals now employ care attendants to sit with patients who are at risk of falling to provide vigilance. So the impact of falls on individuals is far-reaching. The social impact of reduced independence through fear, the potential or loss of independence, and the increased burden on families can be significant. Whilst the risk of falls is well documented for the elderly, falls can occur in all age groups. So it's important to have strategies such as screening to reduce falls and harm. And that they should not be limited just to older Australians. Policies, procedures and protocols for all age groups need to be based on the available evidence and best practice. The risk of falls and harm from falls is high for people with impaired vision, poor balance, muscle weakness, reduced bone intensity, and for those that are on some certain medications. The more risk factors that an individual has, the greater the risk of falls and the ongoing harm. Older people in particular are at increased risk of falls when they enter healthcare facilities. Now, detailed guides are available from the the website. There's a list of them there. You might like to pause and have a look at these and identify them. But I do recommend that you go in and have a look at the website itself. So what are the indicators for quality and safety? And these are related to the areas of priority, which we've just discussed. So that the indicators for quality and concern is that the objectives of the Commission's national indicators are to enhance the quality of safety of focus and to drive improvement in safety and quality at local levels and to improve the transparency and accountability in reporting on healthcare safety and quality. So let's look at some of these. There are indicators on hospital-acquired complications such as pressure injuries, falls, nosocomial infections, surgical complications, unplanned intensive care admission, respiratory complications, venous thromboembolism, and renal failure. There's a national list of 16 of these hospital-acquired complications. The other remaining ones are gastrointestinal bleeding, medication complications, delirium, persistent incontinence, malnutrition, cardiac complications, and 3rd or 4th degree perineal laceration during a vaginal delivery, and neonatal birth trauma. In November 2009, the Health Ministers endorsed the Commission's recommendations that hospitals should routinely monitor and review a success list of indicators. These hospital-based outcome indicators can be generated by jurisdiction or private hospital ownership groups which hold the source data, and they are reported back to provider facilities. The safety quality value lies in developing the Report Review Act cycle based on a routine supply of timely and targeted data back to the hospitals. A number of jurisdictions are already undertaking a similar process with many of the same indicators, and I know that as early as the late 80s, Victoria was doing this routinely. At the time of creating this presentation, the patient safety reporting for hospitals was under construction, and the Commission's ongoing work is to develop a national priority safety measurement model for hospital safety. The aim is to understand adverse event rates in order to inform and support patient safety programs. For patient-reported outcome measures are questionnaires which patients complete. The questionnaires ask for patients' assessment of how health services and interventions have over time affected their quality of life, daily functioning, symptom severity, and other dimensions of health which only patients can know. So these are more the outcomes, the long-term outcomes. These patient-reported outcome measures promise to fill a vital gap in our knowledge about the outcomes and whether healthcare interventions actually make a difference to people's lives. There's also the patient experience in surveys in hospitals. So the Commission's developed a set of 12 Sentinel patient experience questions, formerly known as the NCCQs, for nationally consistent measurement of patient experience. They're known as the Australian Hospital Patient Experience Question Set. And these will be suitable for overnight admission inpatients and day stay patients in both public and private sectors. These have been field tested with approximately 1,500 patients to establish reliability and validity. They're now undergoing endorsement processes with the Commonwealth Health Committees, and once this process is complete, they'll be available to use free of charge. This is a very good opportunity for people. There are also practice level indications of quality and safety for primary health care, and these involve issues of both accessibility and appropriateness. Accessibility means how quickly a person get in to see a GP, and the issues that apply to the appropriate primary health care delivered. There are also the acceptability and the patient participation of how actively does the GP or other primary healthcare person engage the patient or person seeking care with decisions, and the overall effectiveness, both from a consumer perspective and from a system perspective. There are the coordination of care, the referral processes, the content of referrals, because in Australia our GPs are the gatekeepers of the process, and the allocation of a key contact person, or identification of a key contact person or case manager, with timely communication with other health providers. We're also interested in looking at the continuity of care so that there's going to be effective or quick reporting of results, and most importantly, a reconciliation of medication. And finally, there's things like the adverse drug reactions, patient safety investigation, follow-ups, and infection control. There are core outcome indicators for day procedure services. Cancellation of a booked procedure due to a pre-existing medical condition. That is when patients whose procedure has been cancelled upon arrival due to a pre-existing medical condition which should have been recognised prior to booking the service. Unplanned return to operating room, which is an unplanned re-entry to the operating room for a further procedure on the same day as the initial operational procedure, which is an indication that there was something not quite done right in the first place, or a complication that has arisen from the original treatment. Delayed patient discharge for clinical reasons, such as, and this is measured by an unplanned delay in patient discharge for more than 1 hour for clinical reasons, or an unplanned transfer to overnight stay, usually for those that need to be referred or transferred to a hospital or an overnight facility. Now, all of this has led to the development of indicators for Australian clinical standards. And clinical care standards are developed in recognition that appropriateness of clinical care is a major focus in improving the quality of healthcare. And there's a gap exists between what we know and what we do. There's unwarranted variation is a variation in care that's not explained by the clinical circumstances or personal choices of the patient. And unwarranted variation in care occurs in all countries where there is an overuse of treatments or procedures that do not help people to get better, or an underuse of care, which we know that can help, and this is a problem or an adverse outcome of activity-based funding, I might add, and a misuse or errors of doing something incorrectly and harming people. These clinical care standards are in development, but the ones that are published already are in relation to antimicrobial stewardship, acute coronary syndromes, acute stroke, delirium, and hip fracture. The antimicrobial stewardship has found, it's based on the fact that 30% of antibiotics prescribed in Australian hospitals are inappropriate, and this is leading to resistant infections becoming more common. And they have a number of strategies which they'll use, which I won't go into because this is getting a very long presentation. Similarly, with acute coronary syndromes of clinical care standards, that 15% of deaths in Australia due to coronary disease, and despite guidelines, not all people receive the appropriate treatment. So we've got a list of the standards that should be applied if somebody is complaining of coronary care symptoms. Similarly, with cerebrovascular accidents or strokes, that 33% of Australians who have a CVA have a residual disability. Despite the guidelines, not all people receive appropriate treatments. So we have developed simple standards of what's expected. For delirium, it's an acute change in mental status that's common during older people in hospital, and it's characterised by a disturbance of consciousness, attention, cognition and perception that develops over a short period of time, usually hours to a few days. So the standards have developed which are involved in early screening, assessment, prevention and identifying the underlying cause, preventing falls and pressure injuries, and minimising the use of psychotic medications. More than 19,000 hip fractures per annum in Australia, which usually affects those over 65 years of age. And despite the guidelines that have been available for quite a while now, not all people receive the appropriate treatment. So we now have national standards which healthcare providers are expected to provide. In addition to these, we have a list of what's called sentinel events. And sentinel events are a subset of adverse events that can result in death or serious harm to a patient. In April 2004, the Australian Health Ministers determined that public hospitals would report on sentinel events at a national level. And here are a list of the 8 sentinel events that hospitals must report. Now, a sentinel event is something, because if one of these things occurs, it means that there's probably a high likelihood of lack of systemic governance in a health service. And finally, there is the classification of hospital-acquired diagnoses. Now, this is a large area, and I'm not going to go through all of these, but basically the adverse events are described in up to 17 classifications. The classification of hospital-acquired diagnoses, and it's pronounced CHADICs, requires hospitals to identify, count and monitor adverse events that occur in hospital to support safety improvement efforts. So this is a classification to help gather the data and arrange it. What this should suggest to you, that if you are lacking a project to do for ALS, is that there's a huge amount of data already available and standard, so you're not having to invent things from scratch. So the conclusion of this lengthy presentation, and I thank you if you've still stayed the time, is that in Australia we have a nationwide approach to quality and safety in health that ensures, or that attempts to ensure, equity and equality in our health service. It's a developmental process, and it will continue to be developing as we have new discoveries and developments in healthcare, but it ensures that it's based on evidence and best practice. We are committed in Australia to openness and transparency, and above all, it's a worthy enterprise. It's something that we can be proud of as a nation. So I'd like to thank you for lasting the distance, and I hope that you found this presentation intriguing, if not helpful. And if you are excited by this, please enrol in the quality management subject if it's available to you in your course. It's well worth the effort. Okay, thank you very much. Don't feel free to get in contact with me if there's anything that's unclear. I look forward to hearing from you. Thanks again. Bye.